Good morning. Let me ask the speakers on this panel to come forward, please. I have to apologize again today. My voice is no better than it was last night, but I'm very pleased to be able to moderate this session as a substitute for Joe Conn, who could not make it. And let me just tell you about this session. Yesterday, of course, we talked about the use of health information beyond the healthcare setting in some very interesting discussions. And this is the first panel where we're going to talk about the use of healthcare information within the healthcare setting. So we have 5 experts for you this morning, and let me introduce them very briefly. You've got their bios in your course materials, and this is the order in which they will present. First will be Dr. David Chao, the Chief Technology Officer of the Advisory Board Company, and his talk will be, what do you need beyond data to get value from data in healthcare? Our second panelist, Mr. Anil Jain, Chief Medical Information Officer of Explorys, and his talk is the value of health data in driving analytics. Third, Professor Barbara Evans, who is the co-director of the Health Law and Policy Institute at the University of Houston Law Center, and those words just roll right off my tongue. And her talk is patients' access to their own data. Fourth will be Mr. David Muntz, who is the principal deputy in the Office of the National Coordinator at HHS, and he will provide the ONC perspective. And finally, Ms. Kathryn Serkes, the founder and CEO of the Doctor-Patient Medical Association, and her talk is called, How Can We Stop Patients from Lying to Their Doctors? What Patients and Doctors Really Want from a Healthcare Information System. Each of our panelists will speak for 10 minutes. I'll give you all a 1-minute warning, and at 10 minutes this trap door here below the lectern will open and we'll move right to the next speaker. And we should finish at approximately 11 o'clock with our panel discussions, and then your substitute moderator has recruited a substitute moderator for the question and answer session. That will be Deborah Peel, and she'll be here at 11 to do that. So without further ado, I want to welcome Dr. Chao.
Can I just do it from the chair? Yeah, we can just do that. All right, good morning. So what I'm going to provide is just my perspective. This is definitely not prescriptive. So to that end, I want to give you my background and where I come from, and then you can judge and evaluate that along those terms. My background actually is not in healthcare. It's very far from that. I come from a theoretical particle physics background, and I did research in Higgs physics, proposing models of the universe and other things like that for several years before I came back into the software and startup world. So I have a very strong research focus on these questions, and yet I came back into commerce in terms of business. The company that I work at, the Advisory Board Company, we pride ourselves on the service that we provide to our members, but it is still a commercial institution. So it's an interesting mix, and that is essentially where I'm coming from. My company, which I'm going to describe what our approach is the Advisory Board Company. We've got 3 decades in healthcare research and best practices, operational issues and other things like that. Probably the largest company along those lines in the country. Over half the hospitals in the country are members of our research group. Hopefully this gives you an idea of what we focus on and what we value, because what I'm talking about is how do you get value from data? What else do you need besides just the data? First of all, you have to say what the value is. For us, the value is we're trying to help the hospitals succeed, and that is quite difficult these days. They're running at single-digit margins in a payer landscape that is rapidly evolving, and it's absolutely obvious to everyone that what we do today, the status quo, is insufficient for even the immediate future. So something has to change, and they're hoping that data, the insights, will provoke action. Those actions will provide great outcomes. That's what our business is. We've been around for about 3 decades. About a decade ago, we entered technology, and in fact, the way that I joined the Advisory Board Company is I was at a startup, Crimson, which was acquired 9 years ago. And I built out that software and all those teams. We did so because it was the obvious place to go. We were trying to solve the hospital problems, and it was obvious that more and more of the problems were on the technology facilitated side in terms of solutions. So who we are now today is that, just for example, the products that I watch over, our cohort is over 1,000 hospitals in the country. So we have more than a quarter of the country's inpatient data flowing through our applications. We've got 79 million patient encounters, and just in terms of the orders that are being processed on an hourly basis in the hospital, we've got 3.3 billion of those. So we have a good idea of what's going on in the hospitals. We have an awful lot of data, and then this brings me to my topic, which is, assuming you've got data, what else do you need to actually get some value out of it? We have a lot of data, so what else do we need? From our perspective, the first obvious thing is assembling the right team. I won't say that this is the optimal team for everybody. I just wanted to touch on what our combination is. We have our headquarters here in Washington. We've got a floor of about 100 researchers. This is all that they do day in, day out, is answer questions on what best practices are, how to move the dial for hospitals. That's our foundation, and that really flows directly into our products. We have our product teams, software engineers, product managers, and the like. And then we have three other interesting components. We have dedicated advisors. We have folks that are built-in consultants, and they are provided as part of the cost of the software. They are dedicated to providing ROI on the software. And then the other two components are, we've created a research and development team, as well as something that we call Crimson Labs. And the Crimson Labs is very much what I'm going to be talking about today. It's a small team of people who are focused on drawing inferences from this huge data set that we have and seeing what kind of best and worst practices we can share with our membership. So I think a starting point for us beyond the team is figuring out who you're helping. And for us, I said it was hospitals, but honestly, that's a pretty simple-minded answer. I mean, what a hospital is changing pretty rapidly. We've put together a taxonomy of essentially 6 classes of hospitals, and these reflect the rapid evolution from fee-for-service to value-based purchasing. So today's market is an admixture of the following: something like a focused factory, where you are focused on a particular service line, doing that efficiently, doing that the best in the community. So Mount Auburn is an example of that. Elite specialty services, Penn Medicine is an example of that. A scaled hospital system, HCA. Integrated delivery system, Avera Health. Population management, Tucson Medical Center. And then the most ambitious is an integrated delivery system with financing, a financial system tossed in, UPMC, with whom we have a joint venture. So that covers essentially a spectrum from absolute fee-for-service to value-based purchasing. And it's interesting to note that there isn't just one type out there, and even 2 or 3 years from now, there's not going to be one type. Each of those hospitals that are in a particular category are going to be evolving at their own pace. So who we're helping is actually a pretty complicated mix. The kind of value that we provide certainly depends on the people that we're talking to. The next couple things are asking the right question. There's a lot of talk about looking for meaningless variation and unwanted variation in care. That's a great starting point, but one of the things we've done over the last 9 years in Crimson is consider by what dimension, and our dimension is naturally physicians. We've always focused to start off with the care team, because we believe that that's where variation stems from. One of the interesting things is when you look at national data, ours is quite interesting because we have patient and physician attribution. We can see readmissions and all that like on a huge data set. When you look at any large data set, by the central limit theorem, pretty much every graph you see is going to be pretty boring. It's going to look like that. And there's not a lot of insight in that. If you ask the question differently, though, for example, when we look at spinal fusion at a particular hospital, what we see for length of stay for spinal fusion, it looks something like this, and this. So very roughly speaking, it looks like there's 3 modes of care for spinal fusion, almost 3 different lengths of stay that you could select depending on which physician you're seeing at that particular hospital. Sort of begs the question, if you're a patient, do I get to choose the physician, and like which of those is the better one, and what is underlying all that? In the same sense, we've followed on with detailed regression analyses, again, looking at physician attribution across a quarter of the country on a national basis. And we've identified the top 13 DRGs that have physician attributable variation. And it's interesting that the top 2, which are major joint replacement of lower extremity and also spinal fusion, excluding cervical, they have a 40% variation in length of stay attributable to physicians. So when you look at the data, when you ask the right questions, the data can pop and be provocative. I'd say the last thing that I really wanted to hit is, how am I doing? The last thing that I wanted to hit is we focus on putting together insights. We have a team, Crimson Labs, that spends a good amount of their time just cranking out analyses along these lines. But we have these dedicated advisors focused on bringing that out in the field and getting something done, looking for action. I mean, what we want is not the insights. What we want is not the action. What we really want is the outcomes. So they're responsible for the middle tier, and we focused on CHF as an example. We just did an analysis of what our cohort has done. If you index the usage over, say, a 3-year basis, so every one of them, you have them start the clock at the same time, year 0 through year 3, what's interesting is that for the Crimson hospitals as a whole, their case mix index has risen over 3 years usage by about 4%, which relates to much stronger documentation and hopefully better care. But what's interesting is that when you start to stratify, again, this comes to asking the right kind of question. When we stratify the top half percentile, top 50% percentile in terms of usage of our application versus the bottom 50 percentile, very striking things come out. Over those 3 years, the length of stay for the bottom users has risen by about 1% across the board. And the length of stay for the top percentile users has dropped by about 0.2%. The readmission rates for the bottom, the least users, rose by about 8%. And for the highest users, they dropped by about 4%. So you have to ask, what is it that we're doing? We asked exactly that. We went back and we looked at the membership and we tried to draw by induction an analysis of what all they've done. And the bottom line is that they've essentially focused on the things you would expect, but what's interesting is the weighting. So things like right setting, right care, right transition, right prevention, and so on. What we've been able to do is quantify what components of those activities are going to be most important in bringing about changes in something like CHF. CHF is quite interesting because there's a huge amount of variation there. Got a minute? Great.
No,
Oh, that's the time?
yeah.
Okay. So just to close there, just hopefully to give you an idea of the kind of questions we touch on in our approach.
Okay. Thank you very much. Mr. Jain?
Great. I need my slides queued up, I think. Well, good morning, guys. While we get the slides up, real quick show of hands. I heard there's policy wonks and media in the room. How many clinicians are in the room? Okay, great. Technologists, the people that work with technology, great. So what I'm going to do is use a few visuals. My background, I'm an internist by training, but slowly got into the startup world. Let's see. We run a company called Explorys out of Cleveland. It's a startup essentially used to leverage the value of data in the healthcare system.
It is coming very shortly.
Okay. There we go. Thank you.
Sorry about that.
No, that's all right. That's not going to get into my time, is it?
No.
And you can, the button to hit to make
Okay.
it full screen.
Thank you. So I'm going to use the Explorer stories to sort of describe the way we think about value in healthcare data. And our goal is really to improve the value of healthcare data for everybody, especially the patient. Now, again, Explorys was formed back in 2009 as a Cleveland Clinic spinoff, again, to leverage the value of the data that was in the system. The CCF, Cleveland Clinic, actually started their EMR journey back in 1999-2000. And much of that EMR data that was in there, we needed ways to find increasing value, and mainly around research and quality. And I'll explain a little bit about what we've been able to do. Again, what we have tried to do as a company is to bring partners to the table who have a similar interest in leveraging their data to improve care for their patients. The way they improve care for their patients right now has been very, very timely, in the sense that right now there's, over the years, we've known that there's significant issues in healthcare. And now what's happened is a perfect storm. Back in 2010, we know about the Affordable Care Act and high tech and the push for EMRs, both in the ambulatory setting and in the inpatient setting. We also know that there is a significant amount of, in 2009, the high-tech bill, 2010, the Affordable Care Act, which is forming new transformation models for care, talk about accountable care, incentives for shared savings, and such. And then there's also the same exact time an advent and explosion of e-health and personalized medicine and biometric devices. We have beds now that generate volumes of data. We have IV pumps that generate data and send it back to the system. Hip joints that are sending out data. So we need a way for us to be able to analyze all this data, this health data, in a way that adds value to the patient. Transformation is occurring, we know that. There's lots of different models out there. We alluded to the few that are regulatory in nature, but there's also, and David mentioned the same thing about the diminishing margins, and the ability to improve quality while reducing costs is paramount right now in terms of dealing with this. And data happens to be the way that we get transparency as to what's going on. Now, the way Explorys approaches this is that first you have to actually get the data. We've chosen to have a cloud-based strategy to lower the overall impact that getting this information has on the organization, but in addition, it allows us to do this in a safe and secure manner. Because we're able to de-identify and anonymize the data, we can bring it into our grid and make it a lot safer for the patients and for the providers who are willing to share that information in order to improve care for everyone. Once it's in our big data platform, we have a variety of different tools that we use to add value to that data. Maybe it's to look for a gap in care. Maybe it's to understand what's happening with hospital readmission so we can predict those folks who are going to get readmitted shortly. And then we have folks that go into healthcare systems and help researchers and help clinicians understand how to leverage all that information. You know, the way we look at it is that as a software company and as a solutions company, we always have to balance the value that information brings and the security and the respect and dignity that we have for our patients. And at some point, you have to choose something that's going to be in the top left, top right corner to make sure that we're at every given time that we're balancing the need for security and the need for getting this information out there to the right folks. Again, the transformation gap is real. Most health systems, most hospitals, most provider organizations are really thinking about volume-based care. You go see your physicians, and the more they do with you, the likelihood is that the more they'll get paid. And that's changing into a value-based. It's going to be based on who you are, what sort of risk profile you have, what sort of outcomes they're expecting from you, and the quality of care that was delivered to you. That's going to determine the vast majority of how much clinicians and how hospitals are going to get paid in the future. And for that, you need data. I chose to use the Gartner Analytic Ascendancy model to describe what you can actually do with this data. If there's a balance between privacy and the utility of the data, one needs to understand, and patients need to understand what it is that we're able to do with it. So the first example is a descriptive way of looking at performance. I, as a clinician, when I see patients, I need to know how I'm performing compared to my colleagues, compared to my department, compared to the entire organization, and then compared to my peers across the country. And we do that by giving visibility. Now, patients may say, well, why is that important? Because the same kind of visibility can be given to the patients, so they can select the docs that they want to see, the practices they want to go to. Another example is diagnostic. We sometimes use the data to look for patterns that we may be missing by just looking at information on paper or by looking at one patient at a time. Patterns between providers. Why is this provider group that's all the way on the right doing significantly better than the others that are all the way to the left? We need to go in there and understand what drives the best practices, because ultimately that benefits patients. And on the right panel is an example of where we tell clinicians to do things, and if they do those things, we see better outcomes. And this is an analytic graph demonstrating that. But again, patients need to understand that it's not just the data for the sake of data, but it's so that we can actually create increasing value from a patient safety and quality point of view. The next one is predictive, and David alluded to this as well in terms of heart failure. But the first example I'll give you in terms of predicting a price. How many of you folks know when you go see a doctor how much something is going to cost? I don't see any hands. And it's one hand back there. Okay. Well, the reality of it is that we need to be able to do a much better job of predicting cost, because I think as consumers, we're going to start demanding that. And the ability to predict based on our baseline characteristics and based on what we understand is happening from a cost point of view is going to be very helpful to consumers, patients, and to our providers and hospitals, and also our employers who are funding much of our insurance. Going back to heart failure for a moment, how can anyone look at 117 variables that predicts heart failure without actually using data, and lots of it? And now the data doesn't have to be identifiable. It can be de-identified and anonymized, but we still need to have that data in healthcare in order to make this happen. Once you have all these variables, you can take that predictive model and prescribe a certain set of procedures so that you can avoid what's going to happen. If you were to take those patients that have high risk or have any risk of being readmitted, some are going to be low, intermediate, and high, you can then impact that intermediate risk population, because perhaps that high risk population, no matter what you do, nothing may change. But without data, without having access to lots of data, you can't do these kinds of prediction models. And you don't have to re-identify patients until it comes time for actual patient care, which can be done by the provider and the patient together. Here's another example of using this kind of data to find out, of all the things that I could be speaking to a patient about or be intervening on, which ones should I focus on because they're going to have the biggest impact on a patient, either from a patient safety point of view, quality point of view, or a cost point of view. And again, trying to take all that data that's out there for clinicians and trying to give a laser-focused prescriptive analytic so that we can do the right thing for the right patient at the right time. Now, the goal, of course, is our clinicians need to see that there's a difference in our patients. So here's an example of one of our partners in Cincinnati where they were able to improve the pneumococcal vaccination rate. Now, you might think that going from 52 to 60% is not that big of a deal. Why isn't it 100%? Well, there's a lot of things that happen, and most healthcare systems, they're not going to achieve 100% on all the things that they are trying to do. So these improvements in numbers reflect situations where patients are going to have less mortality when they come into a hospital. Because if you get admitted to the hospital and you're old and you get pneumonia, there's a good chance that you may not walk out of that hospital. But if we can give them the vaccines beforehand, there's a good chance we will. Colonoscopies to reduce the chance of a fatal colon cancer, etc. Another example would be going at heart failure. By using data, we can reduce the number of heart failure readmissions. It's good for the patient, it's good for the provider, it's good for the hospital, it's good for society. And the final example is research. If you can accelerate the net new knowledge discovery process by using anonymized aggregate data, then we reduce the chances of what happened with Lila. We reduce the chances of another patient who's going to have identifiable information out there because we're able to aggregate this in an anonymized way and then look for signals and then only then focus on bringing those patients in for clinical trials. I'm going to stop there and I'll take questions later on with the group. Thank you.
Thank you very much. And now, Professor Evans.
Privacy is sometimes conceived as control over your data, and part of that control, of course, is this right to have some control over whether other people are using your data. I want to talk about a little bit different side of privacy and control, and that's, can you get your own data? And in the last 15 years, our country has made great strides through the HIPAA framework, mainly, of recognizing that patients should have the ability to find out what data are out there on them. But there are still some significant gaps such that you can have health data about you that are out there that you have no way to get to see. And I think that creates several concerns. One is obviously just the dignitary concern. It's a matter of autonomy. If health data are out there, I think most of us feel like that concerns us and we'd like to be able to see it. Another thing is knowing what data are out there is part of protecting your privacy. You can't know if your pocket got picked if you didn't know you had any money in your pocket. To police your privacy, you need to know what's there. And then a third aspect of this is that our healthcare system is in a really important period of transition now as it moves from a sort of 20th century curative model where they wait till you get sick and then you go in and they try to cure you. We have scientific ability now to take a more predictive and preventive approach to healthcare, and that is going to change healthcare into a more information-based system where you're assessing your risks and trying to manage them so that you don't get sick. And to do that, it takes a lot of participation by the patient, and you need to be able to take control of your data so that you can watch your risks, and we will not get to that new model of healthcare if we keep data sequestered from the patient. Now, the legal side of this is that there's really no constitutional right that's going to give you access to your data, in part because so much of our data is in private hands and the Constitution protects against government infringements. HIPAA did create a statutory right that if your data are being held by a HIPAA-covered entity, there's a process through which you can request a copy of it and see it. That has always had a major exception in it, and that's that HIPAA accepted labs that are regulated under the Clinical Laboratory Improvements Amendments, which is most clinical labs. So there was this traditional exception that did not give you that right to go to a lab and ask for your lab results. And I'll talk later, there was a proposed rule recently to address that, but that still leaves a lot of entities that are not HIPAA-covered entities that would not be subject to this, and then there are labs that are not CLIA labs. So there are entities there. I suspect some of your organizations are probably not HIPAA-covered entities, so a patient couldn't come to you and say, please tell me what you've got on me. Now, I want to make clear the problem isn't that we have laws that say patients can't have their data. That's not how it works. The way it works is that in many cases, if you had someone that had your data and assume they wanted to give it to you, which is not always the case, but assume they were willing to share your data with you, there may be laws that would punish them for doing so, so that if they share data directly with you, they will have violated some laws. And some of the state laws, there was an excellent study a couple of years ago by White and Daniel that surveyed 55 U.S. jurisdictions, which is the states, the district, and 4 territories. They only found 9 of those jurisdictions that allow a patient to go to a lab and say, please tell me my result directly to me. You have 13 states that say your lab results have to go through your doctor, and then 7 more that say a patient can have data, but only if the doctor says it's okay. The reason this gets to be an issue is that recently there's been a lot of attention to the problem of opportunistic testing. It came up in connection with some recommendations about clinical genetic sequencing, that if you need to get clinical sequencing for one purpose, the lab is recommended that it should go ahead and do 57 other genetic tests because take advantage of the opportunity. And that notion of unconsented extra testing seemed very shocking, but it actually goes on a lot more than some of us realize. If you're a man of a certain age and go get your blood drawn for a cholesterol test, the doctor may order a PSA screening test at the same time. And many states do not require doctors to get consent before they do tests. So conceivably, there's a lot of testing information there about you that you may not even know a test was run. And if doctors are the gatekeepers of whether you can find out which tests were done, they may not disclose those tests that didn't show an actionable finding. So your only way to know that's happening is if you could get the information. Now, there was a very important proposal in 2011 by HHS to amend the CLIA regulation and the HIPAA privacy rule in a way that would let you be able to request from a lab your results in the same way you can from a HIPAA-covered provider. That was a separate rulemaking from this high-tech modifications and was on its own trajectory. And if anyone in the room knows what has become of that rulemaking, I would love to know. I can't see a final rule on it, and it didn't appear to be in the Omnibus Act. So it's an excellent idea. I hope it will move on to final rulemaking. But to my knowledge, and I hope I'm wrong, I don't think it has done so yet. How much time do I have, Mark? I think I can do it. Another really important area, and it's a very small population of people that are affected, but it's important, concerns the research setting. When people volunteer to participate in a research project, information is generated about them, and the question is, can they find it out? This is the question of return of results. And there are a lot of barriers now to doing that. Some of them there's a little part of the CLIA regulation that's a research exception, and if the research is happening in a non-CLIA certified lab, the labs are concerned that if they share results, that's going to make them a clinical lab that needs the CLIA certification. I actually don't read the regulation that way, but naturally it's good to be cautious, and so labs hesitate for that reason. And then there are some ethical concerns about sharing experimental findings, because often they are not well-known tests that have an established significance, and there's concerns that, well, if we share this with people, they'll get really alarmed about a finding that may not really mean anything, or they might not understand it. And I just can understand the rationale for putting ethical review into that interaction between the patient and the researcher. But I ask you, how many of you, if you know someone has test data on you, feels that there should be an intermediary telling you whether it's ethical or not for someone to tell it to you? Or would you like to be the judge of that yourself? You know, this is issues. There's good and bad rationales on both sides of the equation, but some of the rationales are that it might make people anxious or they might not understand it. If that could be a basis for not telling people things, I think we would not have any mathematics in the pre-law curriculum, because math makes lawyers anxious and they don't understand it. So that's not a basis to protect, to stop speech. Occasionally, this leads to some very harsh outcomes where maybe you have a child that has a mysterious illness and is now enrolled in a research project. The researcher spots a gene that they think may explain this mystery and can't tell the family. And so the family is going to be searching year after year, spending money, going to doctors, trying to identify it when the answer may be there. I think there's a simple solution. I'm not saying throw out the whole CLIA regulation. You could do a really specific fix to make an exception for those situations that wouldn't disrupt anything else. It's these little gaps in our ability to see our data that I think we still need to focus on. Thank you.
Thank you. Mr. Muntz?
Ooh, Mr. Muntz, I like this. I have to first of all tell you that I am from Texas and met Deborah Peel when I was working at the state. And the reason I tell you that is I am actually new to Washington. I've only been here about 17 months. I actually am a recovering CIO who had about 40 years of experience in the delivery system. And when I got here, people started asking me how am I making the adjustment. So now people say, well, have you made the adjustment? How is the culture shock? And so my answer is, I think they're getting over it. So I'm feeling pretty good about the progress that's being made here. What I'm going to do is just share some, I'm going to try to be as orderly as I can, if you will recognize that random is one of the orders, and talk a little bit about bits and pieces of what's going on within ONC. I think the most important thing that ONC has done is to actually do what the whole act was supposed to do, which is to stimulate a lot of activity. When I started my career, I actually worked at a hospital that was built in 1969. I didn't go to work there till 1972, so if you're doing the math on age, I'm allowing you to know this, but not to share it with anybody else. But the hospital was built in 1969 without a medical records department, because the value of an electronic health record was already understood. And we really didn't have the ability to create electronic health record because the whole disk storage was 20 megabytes of capacity. But about 8 years after I arrived, we actually did have the entire record, with the exception of nurses' notes. It was a cultural bias. Were actually online. Within the first year I got there, I actually wrote a program, my first online evidence-based approach that looked at microbiology results, and we were a cancer and leukemia hospital that was the only place that was treating children in the Dallas-Fort Worth area who had cancer and leukemia, and they were immunosuppressed, and we were able to look at the in vitro results of microbiology and figure out what was the best regimen to use in treating the patients, and it was significantly different than what you would have seen in the literature. And so for the first 20 patients that we used the computer to do testing, the results were 100% accurate. And again, significantly different than what was done what was reported in the literature or suggested by the literature. And it was there that I ignited my passion. And I think one of the things that probably is true of everybody who is here today is that passion drives you. You have a passion for patients. You have a passion for healthcare. You have a passion for privacy, and I share those passions. And I have seen what it is that can happen when data is shared. And so I appreciate the fact that somebody wanted to talk about leaving things on paper, but when data is shared, it's unlike all other assets, and that the more it is shared, the more value you can accrue from it. And so I appreciate all the efforts that are done here. And by the way, I happen to be customers when I was a CIO of these two companies. So I'm very impressed with what it is they're doing, and agree completely that we are on a journey of discovery. And it's not the patterns that we expect or want to look for, and this is something I learned early in my career, but it's the patterns for things that you don't expect that are the most revealing. And because we're collecting such eclectic, and I don't use the term big data, such eclectic data, that we're able to do things we could never discover before. And so I love the fact that we're focused there now. Again, I'm involved in meaningful use. We're paying a lot of people a lot of money, and we've had some significant successes. And when I say we, it's together, because the ONC doesn't do these installs. ONC is trying to encourage. Well, my whole point is, if we, the government, hadn't intervened several years ago, I'm not sure we would be where we are with EHR adoption, and I know we wouldn't be where we are in terms of standards. And it's that ability to share information and to lower the barriers for entry and exit to vendors that really is critical, and it's for the patients. And we have focused mostly on the providers. I think that's what meaningful use does. What I like about meaningful use really is that it stimulates meaningful conversation. And if you're smart and you have the time and you will take the time to do it, meaningful conversation needs to precede the deployment of any technology. The place where technology is going to fail, where you didn't have the conversation, you didn't ask what you were going to accomplish, you didn't talk about how to measure success. So what we're trying to do is to get people engaged in those meaningful conversations, to begin meaningful use so they can start using things in a meaningful way. And that's how we think about what's going on in our shop. We are focused on trying to go through several transformations, care transformation on a patient basis. We want to make sure the patient is better. We want to make sure that the population is better. And we want to figure out ways to do different models of payment than existed in the past. And so you will see that the regulations that we put out really try to deal with things in that way. And one of the things that's kind of interesting you asked about, and does anybody know how much they paid? Well, within the last 2 weeks, information about payment was released by the Centers for Medicare and Medicaid Services. I'm trying to avoid the use of acronyms and abbreviations, and so hold up your hand if I use one, and I'll try to explain it. It's NBD, no big deal. But we're trying to make it possible for people to make informed decisions. And we've seen some remarkable results come out of just the first 2 weeks, in which the first inpatient data was released, and then a limited amount of outpatient data. I'm hoping that we will release a lot more. I'd like to be the ill-behaved, I think Wonk was I used to be called a nerd. I like that. I'm not sure Wonk is good. Willy Wonka I would like. But nonetheless, trying to go through these incredible transformations. And the regulations are raising the bar on what it is that people are expected to do. And when I was a CIO, we were going to do those things anyway. We may not have done them in the order that was prescribed by the government, but the fact is meaningful use is a diversion, but not a substitution for what was already going on. And so as a CIO, I would write to ONC and, what the hell are you doing? Now I sit inside ONC, what the hell are you doing? In order to make sure that we can do things in the most practical and pragmatic way. Now, most of what we've done is focusing on the providers, and I think that's a wonderful, laudable goal. And we should be doing that. But there's another party that participates in all healthcare, and that's the patient. And we have not paid as much attention to the patient as we should. And it's my experience, both personally and as an observer, that you can deliver all the information that a patient needs to that patient, you're still not going to get a better outcome. And you have got to get the patient engaged. And so one of the people that used to work at ONC, Chuck Friedman, talked about creating a learning health system. Well, I think the learning health system is a good intermediate step, but an engaged health system is where we need to go. And unless you take the lessons that you've learned and apply them in a practical way, you are not going to progress. And so I suggest that we move not only to engagement, but activation. And that's where the patient activity really needs to focus. And the patient needs to have the confidence, and we've seen today cases where it's been shaken, that the data that they share, the relationship they have, is going to be protected, and that they're going to have controls. One of the notions that we're discussing, and I try to push for this, is thinking about the patient as the custodian of record. It used to be that within a healthcare facility, the medical records person or the physician was the custodian of record. We need to change that. When I proposed this in front of the American Health Information Management Association, HIPAA, I thought I was going to get blown away because this is what they do. Well, actually, I got spontaneous applause. Do y'all want to try that just for a minute? Thank you very much. Yeah, you shouldn't have. No, you really shouldn't have. Anyway, spontaneous applause for suggesting that the patient become the custodian of data. That solves patient privacy, confidentiality, and security issues. Okay? And it's wonderful if you happen to be a sophisticated enough patient. So I will continue to push on that. I think that's the right way to do things. The challenge is that there are a lot of people who live on this side of the digital divide and have not crossed it yet. And so health information exchanges are out there in order to facilitate conversations that need to be had. And we're going to have to figure out how to provide that data in a safe and secure manner. So I appreciate what you're doing today and hope that you will continue in a passionate and ill-behaved way to push forward to get what should be done for the patient. Patient advocacy is critical. Thank you.
Thank you. Now, Ms. Serkes.
Thank you. You know, I don't know why I prepare remarks and prepare presentations, and you know, you end up sitting here taking notes after you listen to people and learn so much. It's like, why do I even bother preparing when what you have has prompted so much? Dr. Patient Medical, let me start by just saying Dr. Patient Medical Association is the first association in the country to really bring healthcare professionals, not just physicians, but on all types of practices and patients together. And our idea is to get them communicating much along the lines of what Mr. Muntz was just talking about, to empower patients and to get them to be more engaged, and for them to understand what their doctors and providers are going through, and for the providers to be able to reach out to the patients. So coming from that perspective, you can imagine that we're taking a much less establishment or institutional approach to this. After almost 20 years of coming to DC and working in this, I think most people still have not made the adjustment to me either. So fair warning. I would start this out by saying patients are lying to their doctors. They're lying to protect their privacy. And we know that because several years ago, we surveyed doctors. I've been doing longitudinal surveys of doctors since about 1996, 97 on various attitudes, and this is one of the things that we've checked. 3 out of 4 doctors report that they have been asked by their patients to lie about what they put into their record. Now, only 2 out of 3 doctors admit to falsifying or lying in the record, but I would assume that it's higher than that, if 2 out of 3 have admitted to it. So given that, we have a problem. We have a problem from a clinical side, where we have inaccurate medical records that clinicians are using to treat patients. They have incomplete records, or they have wrong records. And that's not working in favor of the patient. The bottom line is that we have a perspective is that you've heard almost everyone up here talking about really the system, about the healthcare system and our roles in it. But from the perspective, I'm talking about the doctor and I'm talking about the patient. What it comes down to the doctor and the patient is in that exam room, there's the doctor and there's the patient. They don't care about the system. It's about this relationship between these two parties. And that's what they care about. So we know we have a problem. If patients were designing it, if doctors were designing it, what would it look like as far as privacy and a health information system? You know, there is a little bit of a conflict from patients, I will admit that. You read any of the surveys on privacy, and the numbers are off the chart on patients want privacy. They usually be 90%, somewhere in those sorts of numbers, where patients say that they want privacy of their records. But on the other hand, they do want some ease navigating through the system. So let's take a look at what patients want and where that's in conflict. Number one is that they want ease in using their information for clinical purposes. They want all of their doctors, all of their healthcare professionals to be able to share information easily for their actual treatment. Okay? They want to make it easier to file the insurance claims. They want to make sure that it's paid for. They want their families to have access to the information easily. And that's not so easy anymore. And they want to know how much things cost. They want to be able to get to that type of information. So some of those are in conflict. What they don't want is they don't want endless repetition of filling out forms. My father has heart disease, diabetes, non-Hodgkin's lymphoma, and as I always talk about it, I have his permission to talk about this. He doesn't like it, but I have his permission, is that he is not a very compliant patient. And I have been with him, and to fill out forms, and we're answering the same questions. My mother was recently diagnosed, both of my parents are 91. My mother was recently diagnosed with colon cancer. And in the course of one day, I know that we answered the same questions to 6 different parties, the exact same questions over and over again. And that's what patients tire of. Now, I understand the reason for everyone asking the questions, but patients would like to have some sort of seamless sharing of that information so they don't have to do that, especially when they're sick or in the hospital. So, whether that can work or not work, that's what they tell us they want. What they don't want is the repetition. What they don't want is they don't want their employers with access to that information. They're in their medical record. Now, many of you who are familiar with how an HR office works is there may not be that much access, but patients don't know whether there is or not. So something needs to be done to either assure them or take care of the sharing on that level. And what they also don't want is the government access to their information. And this has become very acute to us in the last month or so about government access and the link to medical care, whether that's for benign purposes, to the alphabet soup of agencies and acronyms that they don't understand what NCVHS is or HRQ. They don't know what those are. They don't know what they're doing with the information. To them, that's going into a government pot that anybody can look at their information, and that's very frightening. And then to the point of the IRS or investigative agencies being able to have access to it. And I have heard FBI testify on a same panel I was on at HHS that they would indeed use information found in investigation of Medicare fraud to prosecute patients if they found something in those records. Even would not be considered fruit of the poison tree as it would in many other type of searches without a warrant. So that's what patients do and don't want. Now, what do doctors want? Doctors really want two things. They want to take care of the patient that's in front of them, and then they want to get paid for it. Okay? Now, there's a lot that goes into taking care of that patient. That means maintaining that doctor-patient relationship, maintaining the trust of that doctor-patient relationship, because they will still report to you that that is the most important area, that to maintain that doctor-patient relationship and that trust so that they can have the best information to take care of their patients. And when the trust is broken, as we heard with Lila, that becomes problematic as well. And doctors do want to get paid, and unfortunately we have third-party billing, so it's usually doctors submitting the claims for patients now. And they have to file all kinds of things. What they want records that actually help them take care of patients. They don't want to spend time on somebody else's artificial architecture of an information system that they have to fill out for somebody else's use. That's cumbersome, or they feel that other people will be making money off of that data. And with all due respect to what you're doing here with the systems, is they know that somebody else is making money off of this data that they're told to report. When they hear meaningful use, what they hear is, now I have to get more information. Here's another regulatory hoop for me to jump over when what I'm trying to do is take care of my patient. And now I've got to do this for somebody else. They resent being forced into becoming data collection clerks for government agencies, insurance companies, and everyone else, no matter how benign or well-intentioned that purpose is. And I just want to throw some numbers at you, since I feel compelled to have a little bit of academics here with me. Doctors, we surveyed doctors across the country in all practices, and 67% of doctors say that electronic medical records will compromise patient privacy. That's pretty strong. That's a high number. Only 8% say it will improve patient privacy. And then when we talk about these systems, I have to tell you, when this doctor is not like most doctors that you're going to see. When they see those slides with descriptive analysis and diagnostic analysis and all those numbers, we get the Migo effect, the my eyes glaze over effect, because they don't know what to do with that. They know it's almost unconscious. The diagnostic process is almost an unconscious process for doctors as they go through it. What they see is that we know that doctors say that only 15% say that pay for performance, we're looking at a systematic approach, only 15% say that pay for performance will actually reduce the cost of medicine. And only, and as far as accountable care organizations, this collective, they say 48% say that they will not participate. Only 3% say it's a great idea. So the bottom line is, in conclusion, is that we need to win if we want to move forward on the use of the data and the productive uses of the data, is that we have to win the hearts and the minds of both the doctors and the providers. We need what we almost call we call it privacy literacy. As Dr. Evans pointed out, patients don't know what they don't know. They don't know what's being compromised. So we need to take a look, and this is nonpartisan. Patients need the right to control. They need the right to opt out, to at least in the minimum is to get their information and know all the disclosures, and so that it's being used for effective treatment. And in conclusion, as I said, this is bipartisan. I've spoken on this from everywhere from Tea Party groups across the country to Reverend Al Sharpton's National Action Network, and there is agreement that patients need to become more engaged. And that's another thing the doctor said, is that patients need to become more engaged in the process. So if we can do the education and figure out education, and not in a government way, but through the marketplace and through nonprofit groups, to educate patients and doctors on what the privacy is, how they can control it, and how they can get engaged so that we can have truly informed consent and good use of the data without losing privacy. Thank you.
Thanks to all the panelists, and I would invite you to come to the mics for your questions, and Deborah Peel will take them for you.
Well, I'm really regretting he has to go catch a plane. Can't stay to moderate. So I'm gonna just tell everyone I'm leaving myself out of this, leaving this discussion to you all in the audience. And so, first of all, I want to thank all of you for your wonderful and passionate presentations, some of which had order and randomness, some of which were very efficient, but they were all incredibly informative. And I think the diversity of ideas and thoughts here is certainly mirrored in the audience. And so, what can we say? I mean, I personally agree with things that everyone had to say. And okay, I'm going to inject one thing. The word engagement. We want to engage patients. We want to invite patients. That's not good enough. That's not good enough for me. This is a partnership. I have equal rights to anyone else in this system, perhaps more rights and more deserving of respect. And the baloney of engagement has come along because patients have been excluded from this process. And so that's it. That's my only editorial. Why don't we go to the audience?
I stipulate to your objection.
Okay, thank you.
Perhaps a better word would be empower patients.
Yes.
All right. Boy, you got me seeing red. I'm going to share a little story. I'm a physician about 2.5 years ago at Kaiser, where I discussed with my internist my feelings of disgust, how much we are overdoing the prevention of certain things, such as overdoing labs without patients wanting to. I was up for my 5-year lipids. I said, hey, my HDL was higher than my LDL last time, less than 100. I don't need it. Don't do it. You don't have to. So she agreed, yes, and those drugs are causing lots of side effects, blah, blah, blah. Okay. So I come out with the automated slip, which Kaiser's very good. They've been way ahead of the game. And what do I see? I see a non-fasting lipid, which as an endocrinologist really got me pissed. But, so then I started reeling because I knew a lot of people in the system. My husband works for Kaiser, and so I could kind of go up the chain. And so to understand this, there's Northwest Permanente, which is doctors, and then there's health plans. So I got started thinking, hey, what if this is all about HEDIS scores? What if this is about health plan actually ordering it? I never got the answer to this. But what's most disturbing, about a few weeks ago, Kaiser got reported in the Oregonian about all these HIV tests being ordered without patient consent. Now, I don't know, because the Oregonian reporter did not ask that question. Was this coming from the physician, or was this health plan? Because this push for HIV screening might be pushing the need to get more HIV tests for at-risk compensation down the line for physicians who are going to be compensated more money. Okay, so that's my question I'm throwing out. How do we start really following the trail on who's ordering these tests too under these circumstances where this push for accountability that has nothing to do with the doctor-patient relationship is getting testing that could lead to even false positives and all sorts of bad things?
Who would like to take that?
I just want to say, in my haste to wrap up, when I saw Dr. Rothstein looming over me, I neglected to mention the word transparency in addition to the empowerment. And that is part of the process, is the transparency about exactly what you're talking about, which is you can't even being able to track where that test was ordered, et cetera. Transparency in the process.
Anil, will you have something to say?
Absolutely. I think, if, for example, there is a gap analysis done that a patient should have some certain test for some quality metric, that's not a decision that the insurance company should make or that the office manager should make. That should be between the physician and the patient. Now, the physician has to educate the patient as to why it's important. If the patient says, I don't want that test should not be done. There are situations where if you have a well-controlled diabetic and their tests are, as you know, their tests are doing very well, you may choose not to. That's why performance metrics are not 100%, because there is some individual choice in the process. So if that's happening, that's certainly not something that I would see as being part of some sort of policy or standard operating procedure. Most of the clients that we work with put the physician and the patient in the center of all those decision points around dealing with gaps in care. Ultimately, there's also ability for most quality measurement to select off some sort of data point that says the patient refused, the patient wasn't indicated, or the clinician didn't feel it was necessary. So, I think we blame quality measurement, but really it's, process and anecdotes don't necessarily mean that there's a flaw in the entire system. I think, otherwise we'd be seeing 100% on a lot of these measures, and we don't.
David,
far from it.
You had another response, I think.
Yeah, this is, despite my background, this is not a technological response. One of the things that we started 6 years ago was engaging on clinical integration, formation of organizations along the lines of Advocate and the like. And one of the early lessons was very much on the organizational side, which is, we can talk about the patients, but actually the physicians are the tougher crowd, I think, to start off with, and rightfully so. I think the biggest lesson that we learned is that when we are putting together clinically integrated organizations, when we're constructing patient-centered medical homes, that we have to not just engage the physicians, that we have to make them the driving forces in that. And so that's exactly what we've done in the patient-centered medical homes that we create. So when we talk about panels of measures, metrics that we're going to be following, protocols, those are all constructed by those physicians. Essentially, the problem is thrown back to the PCPs and the specialists to say, here's the general problem that we're trying to solve. What out of our toolbox do you actually want to select from? And then the other thing is that in terms of follow-up and the things that actually guide the care, one of the basic components of patient-centered medical home is bringing in the ambulatory side and cross-network care management. We make those care management, we make the care managers in a number of our institutions we work with identify with the practices. So when the care manager calls up the patient and says, I think you need to do so-and-so, they don't call and say, I'm from so-and-so hospital system, I'm not calling from the hospital, they say, I'm calling from Dr. so-and-so's office. And those care managers are establishing the relationships with the physician. So this is not something that gets imposed, it's something that gets driven by the physicians.
I'd like to let Barbara talk. Great question. You got everybody on the panel going.
Yeah, I just have a brief point that part of the solution to this is transparency and letting patients have access. But there are other aspects. I read a case the other day, Costa versus Boyd, where a doctor let a patient decline a test and then later was held liable for malpractice for not doing the test. And that should be a defense to malpractice if the patient declines it.
Yes,
absolutely.
And I think if you filed it out, it would be. But until we fix the whole constellation of things, it's hard to get a handle on these problems. They're many-sided.
That's the quick comment, is that what the example you give of the tests without the patient's knowledge goes way beyond the issue of privacy. That goes to the issue of consent.
Let's take the next question. Can you top the last?
It's an easier one, I
think.
Oh, okay. The actual sampling that
Can you get closer?
Yeah, sorry. The actual data that you need, the amount of data you need to actually sample and get your conclusions, doesn't have to be 100%. It seems like a significant sample is like 10%. And so that being the case, if we did have an opt-out, opt-in system for the patients, for their data to be pushed through systems like yours, would that affect your business at all?
Would it affect what?
Their business of going through the data and trying to come up with conclusions and how to improve healthcare.
Anil, David?
Yeah, I don't think it would. Right now, we already respect the organizations. We're provider-centric. We deal with hospitals and providers, and if they have data points that suggest that a patient has put restrictions on their medical record, we don't bring that in. And to your question about modeling, our statisticians, I'm not a statistician, but our statisticians tell us that you need a certain number of patients before you get certain value from it. You don't need 100%.
That's right.
But you got to keep in mind, though, at some point, you do need to understand who those patients are, because you do want to make this about the patient. So if you learn something from the model that you now need to impact the patient-provider relationship, you need to know who those people are. So the data is not a question of not ever having access to the data. I think at a certain point in time, for everything we do, we decide where is it important to sample, where is it important to have de-identified, anonymized data, and where do we need to actually have PHI when we do that point of care back to the clinician. So it's a very risk-based approach. But you're absolutely right. You don't need to have 100%, and it would not affect our business model.
And the patients, this brings us to the issue of the granularity as well as the segmentation, is that patients understand, most patients don't want to opt out all of it. There are certain things in their records that they would like to flag or do something with. So if we could get into segmentation and down to this granularity, would make a huge difference in bringing patients along and being willing to use data.
And it would help, it would improve in the separation between the use of the data for clinical purposes versus marketing purposes.
Well, that's certainly the biggest bugaboo to patients is the desire for the clinical use of their information, to make that as easy as possible. And of course, my personal take is that HIPAA got that all backwards and made it harder to use it in clinical and easier to use everywhere else.
And though it may seem a little odd, even though I'm a technologist, I started as a biostatistician, and this has nothing to do with that. But one of the issues that I saw is when people elect to opt out, a lot of time it's because of the stigma that's associated with diseases, mental health being the most common. And my wife suffered from mental health before she committed suicide. And so I'm very sensitive to this. And to the degree that we continue to stigmatize mental health as opposed to how cancer used to be stigmatized, as opposed to, and you just go down the list, until we can have better conversations as members of society and remove the stigma from disease, we will all suffer to some degree. So,
and the penalty through your employer, for example.
Right.
Could I just briefly add in?
Sure.
So I was just saying, actually, incomplete data is really fun for us. We think of that as a great opportunity. Because I think that oftentimes from a research perspective, people take the perspective, if I don't have all the data, I'm not going to be able to get any useful results. I'll give you an example. We were looking at just the question of people using enoxaparin, which is actually pretty expensive, versus heparin as a DVT prophylactic for COPD. And we saw nationally huge variations in hospitals using it or not. We only had a particular kind of data, which is attribution to the specific ordering physician for those hospitals that had implemented CPOE, which is still a minority. But we took that analysis as a sociological test. And what we found out is essentially the actual percentage of cases where you're using enoxaparin versus heparin, 40x difference, is totally just a question of what is the percentage of people who use heparin 100% versus percentage of people who use enoxaparin 100%. There's no in between. It's just a total question of, like, do you have type A or type B physicians? Right. So that's something that we can carry across the entire country. We're pretty comfortable that we've essentially identified archetypes. A lot of our approach is to identify archetypes in physician care protocols and patient care pathways. And for that, we don't have to have complete data. We just have to have enough data to give us samples of what happens in the real world.
Thank you. Great question.
Hi. I have 2 points to make. One is very quick and short, no response is required. I just want to point out that not all patients want their family members knowing their medical history, and I've been very amused by my baby boomer friends about how much of their past they don't want their kids to know. So I just want to point that out. And to a more important and more closer, I had the privilege and honor of being the patient advocate for my mother. I had a PhD in computational neuroscience and was at Mass General Harvard Medical School with a joint appointment, and my mom was diagnosed with stage 4 metastasized melanoma. I moved her up from New York to Boston, brought her to Mass General, and on the way, they first wanted to treat her brain tumor. It was in the cerebellum, and on the way to the hospital, I heard on NPR about gamma knife treatment at New England Medical Center. I was on my way to Mass General. So we met with the radiation oncologist, went through what they were proposing as the standard of care, which is a term I have not yet heard here, and this is the first opportunity I have to really talk to the legal discipline about it. And I kept inquiring about what her treatment options were. She was very fragile. She was 81 years old, and she was pretty much had given up on life at the time. And I kept inquiring, what are the other treatment options? Well, we could treat, yes, we can treat just the cerebellum. We recommend whole brain radiation treatment as a standard of care. If we treat just the cerebellum, it's could result in a 40% chance of the cancer recurring, yada, yada. So every time I kept getting, this is what we recommend as a standard of care. So this sort of speaks to the patients becoming more engaged and making more informed decisions. I was trying to get information about what the prognosis really was with this treatment and with an 81-year-old female, knowing, of course, having done medical research, that she's not where all the tests, well, the studies and the demographics are for the clinical trials. So the bottom line was, when the response was, I said, well, what about Gamma Knife? And the radiation oncologist said to me, well, she said, oh, yes, I know about Gamma Knife. That's at New England Medical Center. They have better marketing than us. I said to myself, end of conversation, I'm going back home to do research. And, so I wound up getting a second opinion. When I talked to the oncologist, my primary care physician, her primary care physician, who later actually took on as mine, she said, talked to the oncologist. The oncologist said, actually, I know that group over at New England Medical Center very well. My wife is the radiation oncologist there. He got me an appointment the very next week when she was starting to have treatment. I didn't know whether even a delay of a week would make a difference. The long story short is it became clear. I went there the next week, spent hours there doing because it was too emotional, so I did a side-by-side. It was clear that that was the treatment of choice for her. She had the treatment the next week. 6 weeks later, her brain PET scan was absolutely clear of the tumor. She lived 7 more years, wound up dying in Mass General, nonetheless, of sepsis after a valvoplasty where they were too aggressive, and was reported 2 years later and was monitored by the state. But they do give a lot of really, really good care, and she was subject to a lot of really good care, as myself was. But this standard of care really goes against giving patients the right treatment, personalized treatment, or even the right treatment, and that's a major concern.
Do you all have comments? Does the standard of care go against patients getting the right treatment at the right time, getting the right information?
I mean,
people are suffering. Yeah. What do you
quick
think?
Comment would be that I look back at my own career. I started practicing right after residency in 1998, and at the time the big thing was evidence-based medicine. It was all about making a choice for the patient based on all the evidence that's been accumulated through various research. And there was some element for the physician-patient relationship and the patient's perspectives. But over the years, I saw, as I was training other residents and students, this shift towards finding out what the patients really want. It was this very empowering activity from the patient's perspective, and we were just facilitating as clinicians to get the patients to understand what their options were. And now we're really embarking on a personalized medicine approach where we're trying to understand, you had the era of crystallized knowledge where the gray-haired gentleman in the room would tell us what we should be doing as we were training, then evidence-based, and now it's personalized where you use your evidence base, you use patient choice, but at the end of the day, there's going to be other characteristics about that patient that's going to guide the therapeutics that you do. So I think the story's not out there yet in terms of the data. We have genomics, we have a lot of data about the patient that we don't consider in the standards of care, and the patient's choice, of course. I just
want to say, because I have to confess that I was embarrassed that I thought the standard of care was actually not illegal. Didn't realize it was a legal term until about a year ago. I didn't fully appreciate, because I just was getting the party line and I wasn't getting the response that I needed in terms of how effective is this treatment or this going to be. So standard of care isn't common knowledge that that's actually legal.
Thank you. Thank you. We're going to take one more quick question because we've got great breakout groups, and I don't have the schedule in front of me. How are we doing? We're a little late? Yes, we are. Okay. All right. Last question, quick question, and then we'll see if you each want to make some closing statement. Thank you.
Okay, I'll try to make this quick. As I see the question about learning, engagement, empowerment, what's the right term? As I see at least one way of thinking about it is putting the patient in the driver's seat or making the patient the CEO of their care team. And I heard a lot of the pieces of that on this, from building the kind of trusting relationships needed with the other other people involved, to giving the data you need, getting access to the information, having the communications tools, starting to take some lessons learned so we start to know what works and what doesn't work, and getting that back in the hands, creating a meaningful conversation. Question was, what's the way, this is probably not a short answer, but what's the way of harmonizing all this or reconciling what was on the stage? 'Cause they're all pieces of this very important puzzle, but I didn't see everything aligning exactly in your presentations.
Well, we'd love for somebody with lots of money to step forward and offer us a grant to go out and do patient literacy and education. Seriously, I'm joking, but we have talked about this, that would be the first step in terms of educating everyone. The one thing we would like not to see is, I understand the suggestion earlier was some sort of a certification or something that somebody had, but I'd like to see that be a non-government solution. And the problem is that everything that's been thrown out has been a regulatory solution as opposed to a market-based solution of working together.
Without wanting to advertise, and I've got to avoid that very carefully, I can tell you that there are private sector companies that do certifications that meet HIPAA requirements. And you can go out there. I know 2 of them. We, at my previous organization, we're on the founding board of one of those, and was the first delivery system to get this certification. So just Google out there, and you should be able to find these. And there are, of course, other consulting companies that would offer those, but there are certification bodies that are non-governmental.
But briefly, just being HIPAA compliant doesn't mean you're really protecting privacy.
Okay. You each, would you each like to have one last word?
I'd just like
about
attitude to you for one of my favorite quotes is that well-behaved women rarely make history, and so I'd like to acknowledge one of our less well-behaved women for what she's done. So thank you.
I'll do my best to live up to that. Thank you. Thank you. Okay. All right. So
I just want to have one wrap up, and that is when you're looking at the privacy aspects, the legal aspects in practice of privacy, I would just like for you to recall Lila. Think of Lila whenever you're looking at this issue in the future, and keep that as your guide.
Okay. Thank you all so much, panel. You were terrific, and thank you all for the great questions. We kind of goofed up the break a little bit, but there's break food and drink out there, which grab something, please, and we can hopefully start not too long after 11:30. CIOs and privacy should be fabulous. Room 203. The omnibus privacy rule, and where are we? Will be here in Hart. Newtown and the privacy of psychiatric data will be 205. Consent for research, do we need it, will be 202. And what's next for data segmentation will be 201. So these are terrific. I thought we were going to have a slide. Sorry. Okay. CIOs 203. Omnibus privacy rule right here. Newtown 205. Consent for research 202. And
we're excited.
Data segmentation 201. Thank you. So thank you very much, and then we'll see you back here at 12:40 for Mel Urofsky and Brandeis. Oh, not here. Excuse me, no. I'm sorry. Okay, the luncheon is 12:40 across the street at the Washington Court in the Atrium Ballroom. 12:40. It'll be fabulous. Please come and hear from Mel. And your lunch is free, so you shouldn't miss it. Okay.
Thank you for the work most of you guys are doing on. I run a small foundation working on trying to create a learning health system. The work you guys are doing is.
In 10 minutes, we couldn't talk about everything we're doing,
Of course,
we're
I mean, the whole idea
about the
is
next
take all the different learning
generation.
activities.
Absolutely. Thank you.
Actually, he mentioned Chuck Friedman from ONC, who I called. I called Chuck Friedman as soon as he left ONC. That's my partner in crime.
Oh, okay.
Taken off. Good to see you. pleasure, as
Please
always.
thank Kathy again
Yes,
for all of her
Not
help.
sure where she
and
is right now.
Thank you so much.
Well,
and
thank
Lila's,
you.
your
She was
conversation
great.
with Lila was
She was
fantastic.
great.
She was so good, and you were great. And
Well, hopefully it went well from my end, but most importantly, I thought it went
it
well.
really
from
went
her
well
end.
from her end.
Yeah.
She is so captivating.
Yeah,
so,
she is.
so I guess we'll be in touch after.
Okay, good. Take
Okay,
care.
great.
Good to see you.
Good to
Pleasure.
see you
Keep up
too.
the good work.
Thanks.
You want me to hand it to him so you can go see Joy?
I'll see you.
I'm gonna go on up.
All right.
Hi. Oh, do you need to do something? Or? And then Susan was going to be last. And you and I can't remember. Okay. 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 Well, I don't know. We'll just, it's good to have a diversity of approaches anyway. So.
How you integrate it. Yeah, like, I just, right. No. No, okay. I have a quick one.
Yes, yes.
So, my name's David.
Yes, oh, good. I like them.
Yeah, and our company has a couple, we're under the,
Okay. And the biggest, I'm here.
we have some task order ideas.
I'm here to talk about
That I thought you might be interested in taking a look at.
Is it down in Houston? Oh, this is Dallas.
Yeah, but it's so this is
Very good. Oh, you're one of those? Oh, great. Super.
We're one of those. Yeah, well,
Make it work.
I've written like 9 standards. But we have some great ideas about improving patient consent if you want us to talk.
I'd love to.
All right, please do.
That's what I want to too. But
Thank you very much.
you're the third. We need to have some